And I request Professor Albert, Chairman, Department of Neurosurgery at Russia, to speak on the recent advances in surgery for glioma.
Okay, possible? Possible, yeah?
Yes, Professor Albert, you can share your screen. Yes, we can see.
Okay, thank you. Good day for everybody. Thank you very much for invitation. My team to share our experience about the glioma surgery, and today I want to speak about the glioma surgery with using ICT hybrid operation room experience. I am from two main cities from the Russia, the midpoint of the Siberia of the Russia, and I present the team of the Center of Neurosurgery, and we have now 15 years of experience and more than 7 cases totally, and near the 5,000 elective cases per year. So now again, about our equipment for this kind of surgery, because glioma surgery is not so easy, not so simple at first, and so why just to make some adventures, we introduce some new technology. So why one of the first is the hybrid ICT operation room. You see the CT by the rails go during the surgery. It's possible to in any stage, if you have some question during the surgery, make the CT and the CT with automatic registration possibility also. Okay, another very important new tools for this kind of surgery is 3D exoscope. Why is 3D exoscope? Because during the surgery, the glioma tissue is not well differentiated from the normal tissue. So why color differentiation, white black differentiation? It's very important just to distinguish the border between normal tissue and the pathologic tissue. And also 3D depths of the visual give us more additional safety and good possibility for this kind of surgeries also. So 3D exoscope now one of the main advantages in glioma surgery also. Not only exoscope personally, also we combine endo and exoscopic surgery both together. So some, if necessary, just to see some remnants around the corner, for example, we use also combination of the exoscope. You see on this slide, exoscope and the exoscope. And it is very safely now compared to the microscope, just to introduce endoscope in the depth wound without any with big safety. So the problem in glioma surgery, one of the most problems in glioma surgery is not achieving total tumor resection. So why we have a lot of possibilities, ultrasound, 5-ALA, ICT, neuronavigation, fluorescein, and so many methods just to improve this total tumor resection. But in our idea is that not only one technology is possible just to have good results. So combination of these methods together, for example, ICT, ultrasound, neuronavigation, and so on, give us more possibilities for this challenge type of surgery. Why ICT perfusion? Because we know what two of the most important factors in determining the malignancy of the gliomas is the ability of the infiltrate the brain parenchyma, and the second one very important is the recruit or synthesize vascular networks for the further growth, neuroangiogenesis. So CT perfusion especially in high-grade gliomas, can be give us more possibilities to total removing of this tumor. Computed tomography perfusion, CTP imaging. Perfusion imaging using CT can provide additional information about tumor vascularity and angiogenesis for characterizing the glioma. The CTP provides a linear relationship between tissue attenuation and tissue concentration of a contrast agent, unlike perfusion of MRI imaging. And hence probably provides a more robust and less biased estimation of the hemodynamic tumor blood volume and physiologic tumor vascular likeness parameters. So, why the intraoperative CT perfusion compares the MRI give us better possibility just to visualize CT in the glioma, and not only glioma, and the most important, the remnants of the glioma. You see on the slide, and you see the CT perfusion, and you see the remnants just we see and when removed after this visualization. So why CT brain perfusion have big advantages now? It's very fast, available, suitable for the invasive care patients, affordable, safe with different implants, high spatial resolution, robust quantification, CBV and permeability can be measured with the same study and automatic registration in CT. But also have some disadvantages. Small lesions may be missed, limited visualization of the posterior fossa, complication associated with the contrast administration and radiation dose. But current CT machines, current CT device just diminished all these disadvantages. So not only our view for this kind of surgery, and also some people in the world also have experience with the ICT perfusion and have also same view. Surgical resection using ICT may improve the outcomes of the patients with the lower grade glioma. For example, our Japanese colleagues present his results, and you see the if make surgery without ICT group, don't see the remnant. If use ICT group, so a lot of remnants see, and additional resection needed. Also, very important tools for this kind of surgery. We combine it with the ICT's interpretive ultrasound in glioma surgery. So one of the most important is the correction for the brain shift, and the remnant visualization. And you see on the slide how it's possible during the operation room. This is our CT and ultrasound probe navigated for this kind of surgery, and you see the full screen about this procedure. Another one of the most important for this kind of technology is intraoperative ultrasound is very important for the vascular landmarks recognized. And you see on this short video, how it's possible to visualize main vessels inside of the tumor. So this possibility can give us more safety during the surgery. And another one of the most important tools is the automatic registration. And you see in our operation room, we have very special CT with possibility of the automatic registration. Okay. And at the end, this is our special operation room just for glioma surgery. And you see there's a lot of equipment inside. For example, exoscope, ICT, 3D screens, ultrasound, navigation, and neuromonitoring, interpretive neuromonitoring. You see the special suction device with navigated suction device with neuromonitoring possibility from the tip. Do you see the ultrasound, navigated ultrasound also? And you see the special 3D screen from the exoscope. And this is ICT. So how we use our technology with CT? So we have low-grade gliomas, so native CT and interpretive ultrasound is sometimes it's enough for complete tumor removal. If we have high-grade glioma, so ICT perfusion is a very important step. It's very important and one of the main steps for this kind of surgery, and additionally with interpretive ultrasound. But again, CT perfusion is most important to see the remnants. So this is now our cases about this presentation. What I said before, I want to present some patient, male, 46 years, with high-grade glioma. This is MRI perfusion, is MRI before, and this is our surgery. So at first, ultrasound navigation we use just to recognize tumors through the dura, and you see the ultrasound picture. You see the tumor very well, and you see the lateral ventricle, third ventricle, and so on. After recognize the tumor, just we open the dura. And you see the main vascular landmarks, what we recognized before by ultrasound, for example, big vein. And one of the most important steps is just to save this big venous pathway. We open the arachnoid, devascularize the tumor by cutting the vessels after coagulation. And when we start debulking of the tumor, and piece by piece we remove tumor in this way. And during this kind of surgery, we use, you see, the special suction device, what give us possibility of the interpretive neuromonitoring possibility. So we, during the suction of the tumor, we know where is the main important tracts. Also, we use ultrasound, also with possibility of interpretive neuromonitoring. You see that from Sanoka company. So this combination gives a big safety for the function of the patient, for the safe function of the patient, motor function. And we achieve gross total resection. You see our interpretive CT perfusion, and you see the total removing without any remnants. This is the control of our interpretive ultrasound possibility. This is the morphology, glioblastoma, grade 4. Another case, it's a low-grade glioma. It's a female, 53 years, and you see the MRI before, just near the precentral gyrus with motor functions. So it's very risky for the loss of the motor function of patient after surgery. So why we use our ICT possibilities. And you see MRI with contrast, but no good body. This is perfusion before operation, and this is our planning of the surgery before. It's 3D model with corticospinal tract, and you see the corticospinal is just behind the tumor, and you see the main vessels around the tumors. This is our operation plan, just for removing. Just we recognize before the plan main landmarks, like gyrus, tracts, volume of the tumor, vessels landmarks, and so on. And mainly we create this our knowledge for the 3D models. This is patient position. This is special equipment. You see the special frame. This frame used with ICT, with no metal. Special Dora frame. This is carbon, from carbon. And again, first step, we open the dura mater. This is supersagittal sinus here. Sometimes use a special knife. It's very useful if brain have some edema, just to prevent injury of the brain during the open the dura. Second step, we recognize main landmarks, especially vascular landmarks, and especially vein. Again, we will see before the surgery special model, the pressure gyrus, corticospinal tracts, and now we see the operation field. This is a tumor. This is drainage veins, most important drainage vein. It's completely correlate with our 3D models. This is very important for the surgeon. Just understand before the surgery in 3D. Then we start the surgery. Just open intercommissural fissure. We dissect all veins, you see, just to save these veins, drainage. Now, next step is very important, the monitor mapping of the main functions. And we just recognize the placental gyrus, very correct, by the mapping. Just to try to recognize the function, motor functions. Step by step. Now we use ultrasound also, interpretive ultrasound, navigated ultrasound, just to additionally recognize the body of this kind of tumor. And then start to remove the tumor. First one, open the arachnoid. And the most important step is we must to preserve the main venous drainage. You see, like this one. And start to remove. And in this step, we use, you see, special ultrasound, special suction device with the possibility of the interpretive neuromonitoring, because it's a very dangerous place, and corticospinal tract is very close. And step by step, we again save the main venous drainage. You see, like this. Constant intraoperative monitoring by the suction. Constant. It gives us possibility for the gross total resection. Again, Sanoka also we use. Sanoka also have the function possibility for the monitoring, interpretive monitoring. So you see. This is our result, gross total resection. This is the size. This is the morphology, astrocytoma, grade 2. Another good possibility, and sometimes we combine it also in glioma surgery, is a laser technology. It's possible to use additionally for this gross total resection also photodynamic therapy. We have not lot of, but some drugs like a photalone, for example, and it's possible to irradiate. And this is the morphology you see before irradiation. This is after destruct additionally the tumor cells, and also give more survival rate for the patient. That's how I do it. So after I remove gross totally remove the tumor, I additionally use the laser on the cavity into the cavity of the tumor. And you see this is the dose, time, and so on. Powerful of the laser. So also very good option. Also a very good option for this kind of surgery. Additionally, another one of the most important step to improve our result in glioma surgery. I mean the education in glioma surgery must improve the outcome. So first one is neuroanatomy. White matter dissection is one of the important tools. We must improve microsurgical technique, and we must have a simulating training for glioma surgery also. Education for glioma surgery also very important, like technology. So we have good lab for this kind of surgery. For you see my lab with 3D just for this is the courses about the white matter dissection. This is our courses for the microsurgical training, microsurgical technique improving. See, and this is our simulation training for glioma surgery. And you see, this is a special simulator, 3D simulation, and give a lot of knowledge before surgery for our residents. We have educational activities because not only glioma but neurosurgery is need learning curve. So why we open for the collaboration and welcome for this our educational activity. Thank you very much.
Thank you, Professor Sufianov. This detailed explanation of your technological tools which you used in operating room, also your education method. Thanks for everything. We will accept questions after all lectures, and we will continue with the